Uh, Good morning. Today I'm going to discuss about neuromuscular junction. So this is otherwise called myoneural junction. So the learning objectives of today's classes: describe the structure of neuromuscular junction, mechanism of transmission of impulses across the neuromuscular junction, neuromuscular blockers, that's the drugs used to block the neuromuscular transmission, and some diseases like myasthenia gravis, Lambert-Eaton syndrome. This comes under applied aspect. So coming on to neuromuscular junction. So as you all know, the muscles are supplied by nerves. So nerves they carry the impulses from the central nervous system. The command is coming through the nerves, and then nerves transmit the impulses to the muscles through the neuromuscular junction. The impulse is transmitted as chemical synapse through the chemical synapse. Chemicals are released from the neuron to the muscle, so the information is transmitted. So neuromuscular junction is a junction between a motor neuron and a muscle fiber, is known as neuromuscular junction. So in this diagram you can see this is the motor neuron, this is the muscle, this is the area where we call it as neuromuscular junction, where the axon terminal communicates with the muscle membrane. So the muscle membrane is called sarcolemma, and the axon actually the action potential arrives from the axon and it ends in the axon terminal, and it leads to release of neurotransmitters into the synapse. This is the space between axon terminal and the postsynaptic membrane. It's called synaptic cleft, where the neurotransmitters are released. So it is a type of chemical synapse. It is visible under microscope. So coming on to structure of neuromuscular junction, there are three structures present in neuromuscular junction. One is the presynaptic terminal, which is otherwise called as axon terminal, a terminal button. The next one is synaptic cleft. Another one is postsynaptic membrane, otherwise called as end plate membrane. So we should see each one of the structures elaborately. First, coming on to presynaptic terminal. Presynaptic terminal is actually the terminal portion of that is motor neuron, which is called as axon terminal or terminal button. You can see the motor neuron supplying the muscle fiber, and this is the axon. Actually, the longest process of neuron is the axon. So what happens, the before supplying to the muscle fiber, the axon divides into multiple branches, and each branch supplies a single muscle fiber. Okay, that is called as neuromuscular junction. So one motor neuron and its branches and the muscle fibers supplied by the branches, all this collectively called as motor unit. So in this diagram you can see this is the axon, and it divides into multiple branches, and each branch forms axon terminal, and the axon terminal actually communicates with the muscle fiber. The axon terminal is the place where there is a collection of neurotransmitters present as a vesicles. The neurotransmitters are stored in vesicles. You can see here, these are all the neurotransmitters, vesicles, and once the impulse came, it is released into the synaptic cleft. So this is the axon terminal, where it is you can see that mitochondria, excess mitochondria is there, and there is excessive vesicles are also there, and you can see the dense tufts, and there is an active zone is there. Active zone is the area where the neurotransmitter vesicles are concentrated. That is, it is the presynaptic membrane where the vesicles are concentrated. It is called active zone. Coming on to synaptic cleft is the junction or the gap between presynaptic terminal and postsynaptic membrane, which is average 15 nanometer in wide gap between axon terminal and muscle fiber. So this is the area where the synaptic cleft is present. You can see this is the presynaptic terminal, this is the end plate membrane, and there is a pink color substance is there. No? That is the area where the synaptic cleft is located. There are fibers like collagen, glycoproteins, extracellular fluid matrix. All these are filled in the synaptic cleft, and acetylcholinesterase, the enzyme that is also present in the synaptic cleft. Okay, postsynaptic membrane. So this is a postsynaptic membrane. You can see acetylcholine binding areas. They are called as ligand gated channels. Basically, they gets activated once the ligand gets binded with the receptor. It is a receptor. It is called nicotinic acetylcholine receptors. The blue color structures. They are actually the channels, protein channels, and they act as a receptor also. So once the acetylcholine binds with these acetylcholine receptors, the channel opens. It allows the entry of sodium, and the end plate potential is formed. So in this diagram, you can see this is the acetylcholine receptors, which are nicotinic acetylcholine receptor, where the acetylcholine binds to the receptor and opens the channel. So it acts as a receptor as well as protein channel. So coming on to the mechanism of transmission of impulses, the neuromuscular junction. The first one is the arrival of action potential through the axon. When it reaches the action potential reaches the axon terminal, there will be depolarization of the axon terminal, and immediately what happens, the depolarization opens the voltage gated calcium channels. Here you can see voltage gated calcium channels gets opened once the action potential arrives the axon terminal. So that opening causes calcium entry into the axon terminal. So once the calcium enters into the axon terminal, there will be opening of vesicles. These vesicles are calcium mediated exocytosis happens. So the vesicle releases into the synaptic cleft. Okay. So basically, some proteins helps in the release of vesicles into the synaptic cleft. We'll discuss the about the proteins in the next slide. And the next one is once the acetylcholine is released into the synaptic cleft, the acetylcholine binds with the nicotinic acetylcholine receptors in the postsynaptic membrane, and the membrane, the channel opens that allows the entry of sodium into the postsynaptic membrane, and that causes the end plate potential. That causes the end plate potential, and the end plate potential, if it reaches the firing level, it leads to opening of voltage gated sodium channels, and once that sodium influx happens, it produces action potential in the postsynaptic membrane that forms the action potential, spreading of action potential in the muscle membrane. So the presynaptic events I already discussed. Action potential arrives, depolarization of the axon terminal, there is opening of calcium channels, there is voltage gated calcium channels, calcium enters in, that causes exocytosis of the vesicles. So that process is called docking. Docking is the sitting of the vesicles into the presynaptic membrane, and it opens into the synaptic cleft. So that is called quantal release. Some proteins I mentioned helps in the exocytosis. One is this synaptobrumin, which is present in the vesicular membrane. Another one is syntaxin, which is present in the axon terminal membrane. So there will be communication between the syntaxin and synaptobrumin, and that syntaxin pulls the synaptobrumin, and so that the vesicles lower down and it touches the axon terminal. Once the vesicular membrane and presynaptic membrane fuses, there will be opening of the vesicle into the synaptic cleft and releases the acetylcholine. And events in synaptic cleft. What happens in synaptic cleft? The released acetylcholine diffuse into the synaptic cleft. Some of the acetylcholine hydrolyzed by the acetylcholine enzyme, which is present, that is acetylcholine esterase, that is the enzyme which destroys the acetylcholine, which is called acetylcholine esterase, into acetate and choline. Choline can be reuptake into the presynaptic terminal for the synthesis of acetylcholine, and acetate diffuses into the extracellular fluid. Some diffuse out of the synaptic cleft into the extracellular. Even the acetylcholine also diffuse into the extracellular fluid, some amount, and some reaches the motor end plate and binds with nicotinic acetylcholine receptors and participate in the neuromuscular transmission. The postsynaptic events. Once the vesicles are released, acetylcholine binds with the nicotinic acetylcholine receptors. Uh, the ligand-gated channels gets opened, and there will be entry of sodium inside and potassium outside. But it is the gradient is more for the sodium. So sodium entry will be more than the potassium efflux. Since it is a cationic channel, only it allows the entry of positive ions in and out of the channels. But sodium influx will be more than the potassium efflux. So that leads to more positivity entering into the postsynaptic membrane that causes depolarization of the postsynaptic membrane. It is called end plate potential. It is called end plate potential. Once that end plate potential reaches the firing level, there will be opening of the other channel, which is called voltage gated sodium channel. So there will be entry of sodium into the end plate membrane that produces the action potential, and the action potential spreads throughout the muscle membrane. One more thing I need to say is the axon terminal is located in the center of the muscle fiber, middle of the muscle fiber. So the action potential can propagate in both the directions, the right side also and the left side also. So the action potential spreads in both the directions because the axon terminal is located in the center of the muscle membrane. So, few points about the nicotinic acetylcholine receptor. It is a metabotropic receptor which has alpha, beta, and delta and gamma subunits. And the acetylcholine binding site is located in the alpha subunit. So once the acetylcholine binds with the alpha subunit, the channel opens. The channel opens. It allows the entry of sodium and potassium ions. So coming on to end plate potential. End plate potential is the potential which is formed at the motor end plate, that is the muscle membrane, after the opening of ligand-gated sodium channels. So the large influx of sodium ions leads to large number of positive charge in the muscle. Okay, so this creates a local positive potential in the membrane. It is called end plate potential. It is usually about 50 to 70 millivolts. 50 to 70 millivolts. So if the end plate potential reaches the firing level, it leads to action potential. It leads to action potential by opening of voltage gated sodium channels. So the end plate potential is actually a pre-potential. It is a graded potential. Okay, once it reaches the firing level only, it leads to action potential. It's a depolarizing potential. It's proportional to the amount of acetylcholine. If the acetylcholine release is more, end plate potential is also, the amplitude also more. If the acetylcholine release is less, the end plate potential amplitude also less. Okay, so if more amount of acetylcholine is released, it definitely going to fire. It reaches the firing level, and it leads to action potential. Okay, so end plate potential of 15 millivolts is enough to bring membrane potential to firing level. A miniature end plate potential. The another potential is present in the motor membranous, muscle membranous miniature, which is it is a lesser potential than the motor end plate potential, which is present during the rest time. Okay, rest, there will be spontaneous release of very few vesicles of acetylcholine. So minimal amount of acetylcholine, very few vesicles once it release. So that will not produce a end plate potential, but there will be some amount of positive potential happens. It is a depolarizing potential, but it is very less. That is less than 4 millivolt in amplitude. So it cannot produce a firing level. It cannot reach a firing level. So that is what it is called as miniature end plate, but it is present during rest time, even without action potential coming through the axon terminal. Spontaneously, few acetylcholine vesicles gets released. That is the reason for miniature end plate potential. And coming on to the fate of acetylcholine. So the acetylcholine released from the presynaptic terminal is some part is attaches with the nicotinic acetylcholine receptors and participate in the impulse transmission. There some acetylcholine gets destroyed by the acetylcholine esterase enzyme. That enzyme cleaves the acetylcholine into acetate and choline. Choline is getting reabsorbed into the again into the presynaptic terminal and forms the acetylcholine. Coming on to neuromuscular blockers, um, these are the drugs which prevent the transmission of impulses from nerve fiber into the muscle through the neuromuscular junction. So they are used during anesthesia to relax the skeletal muscle before surgeries, and they induce the paralysis so the surgery can be conducted smoothly. So coming on to neuromuscular blocking agent, they are the main reason is they fail to generate the end plate potential in muscle membrane. That leads to failure to produce action potential in skeletal muscle. The skeletal muscle paralysis happens, but we need to be careful because these drugs can cause respiratory paralysis by paralyzing the diaphragm and the external intercostal muscles, so that the person can go for respiratory arrest. So we should be careful in using these drugs, and they can act as toxins also, and they can be used as uh, uh, bioterrorism. Okay, so the drugs are classified into presynaptic blockers, postsynaptic blockers, and anticholinesterase. Presynaptic blockers are botulinum toxin and hemicholineum. So as the name tells, it is a presynaptic blockers. They inhibit the release of acetylcholine into the synaptic cleft. So the botulinum toxin is derived from Clostridium botulinum. It inactivates the syntaxin, synaptoprimine. These two proteins are involved in the exocytosis of the vesicles. So botulinum toxin prevents these proteins, so vesicles will not come and attach with the presynaptic terminal, and acetylcholine is not released. So acetylcholine is not there, so the impulse cannot be transmitted. Hemicholineum inhibits the choline uptake, reuptake by the presynaptic terminal, that leads to depletion of acetylcholine. So acetylcholine resynthesis will be affected. So these drugs used. So this is the action of botulinum toxin. The botulinum toxin prevents the syntaxin and synaptoprimine, inactivates it so that vesicles cannot exocytosis into the synaptic cleft. So this can be treated for treating the wrinkles of forehead and treating some strabismus in the eyeball, that is eyeball muscles, relaxing the eyeball extraocular muscles, and treatment for achalasia cardia. So the lower end of the esophagus is more spasm of the lower esophagus causes achalasia cardia, so that also we can treat them, and it can be used for bioterrorism also. The famous actor used this as the for anti-aging purpose and prevent the wrinkles in the forehead. Coming on to postsynaptic blockers. Postsynaptic blockers are competitive blockers and depolarizing blockers. As the name tells, it is a postsynaptic blockers is the drugs and chemicals. They block the mostly the acetylcholine, nicotinic acetylcholine receptors. Okay, so that is why it is called postsynaptic blockers. And depolarizing blockers: succinylcholine, carbacycline, carbamylcholine, decamethonium, anticholinesterase. Competitive blockers are DT-bocurarin, galamine, and bongorotaxin. So the competitive blockers, they attaches with the nicotinic acetylcholine receptor, and acetylcholine cannot bind with the nicotinic acetylcholine receptor, so the impulse transmission will not happen. So these drugs compete with acetylcholine to bind with the receptor, and these drugs don't have the uh, biological activity of acetylcholine. So impulse transmission will not be there. So that is competitive blockers. No action potential, absence of that, no AP and muscle contraction. Depolarizing blockers. Actually, succinylcholine decamethate, when they bind with the receptor, these agents causes they act like acetylcholine. They bind with acetylcholine receptor and they act like acetylcholine, and they open the ligand-gated channels and depolarize the motor end plate for a longer duration than acetylcholine. So that means these drugs cannot be destroyed by acetylcholine esterase enzyme. So these drugs act for a longer duration of time, and so the ligand-gated channels open for a longer duration that produces depolarization of the muscle membrane. So finally, the subsequent action potentials cannot stimulate the postsynaptic, that is motor end plate membrane. So there will be flaccid paralysis of the muscle happens when you use depolarizing potential. So in lower doses, they facilitate the neuromuscular transmission because these drugs act as an acetylcholine. So in lower doses, they facilitate the neuromuscular transmission, but in larger doses, they act as a depolarizing blockers because there will be sustained opening of the ion channel. So they won't respond to further subsequent action potentials that leads to paralysis of the muscles. So large doses produce flaccid paralysis due to depolation of the channels for longer time. So muscle is refractory to the further stimulus, that is depolarizing blockers. So desensitization of ligand-gated channel, motor end plate. Anticholinesterase, the other substances, these are also acts like depolarizing agents. There are two types: reversible anticholinesterase and irreversible anticholinesterase. As the name tells, it is anticholinesterase. That means they destroy the acetylcholinesterase enzyme. So acetylcholinesterase enzyme is destroyed, so acetylcholine will be more. So acetylcholine will not be destroyed. So the amount of acetylcholine in the synaptic cleft is more. So that the action of acetylcholine will be increased. So longer duration of acetylcholine acts on the postsynaptic membrane. That also produces a kind of depolarizing block. So these drugs compete with acetylcholine to bind with the acetylcholine esterase and destroys the acetylcholine esterase. So acetylcholine cannot be hydrolyzed. Excess acetylcholine is present in the synaptic cleft, prolonged the action of acetylcholine. Repeated stimulation leads to muscle spasm like depolarizing block. The examples are neostigmine and phasostigmine. Irreversible blockers are organophosphorus components. They are used for pesticides and nerve gases. So they bind with anti-acetylcholine esterase tightly and irreversibly, and excess acetylcholine in the synaptic cleft causes prolonged action of acetylcholine. There will be sustained depolarization of the end plate. So these drugs are used as a pesticides. So most common substances used for farmers to commit suicide, that is organophosphorus. So coming on to disorders, myasthenia gravis and Lambert-Eaton syndrome. First, myasthenia gravis. Myasthenia gravis is the autoimmune disorder, which is the autoantibodies are produced against the nicotinic acetylcholine receptors in the postsynaptic membrane. So what happens? There will be endocytes. The number of receptor decreases. So even though the acetylcholine is present, the number of receptor is less, so the transmission will be less. So decrease in number of acetylcholine receptor in the muscle end plate. So the coming to the clinical features, the person feels fatigue, weakness, skeletal muscle fatigability. Women are affected more than men. Muscle weakness more in the evening, improves after rest. Because even there will be a concept called running down of acetylcholine. So the initial muscle contractions, there will be excessive release of acetylcholine, and subsequent muscle contractions or subsequent nerve stimulation produces less release of acetylcholine into the synapse. So that is called as a rundown. So along with receptor, the less number of receptors, nicotinic acetylcholine, the acetylcholine also decreased. So that's why the person feels fatigue during the evening time, and even in the morning time they'll feel fresh because of uh, acetylcholine present in higher volume. Extraocular muscles in the eyelids involved early because of the constant activity of extraocular muscles. Extraocular muscles are continuously acting, so they'll go for fatigue early than other muscles. Proximal limb muscles are also affected more. In severe cases, there will be respiratory paralysis happen that leads to death. The famous celebrity who has myasthenia gravis, and he is getting treatment for that. Coming on to treatment of myasthenia gravis, neostigmine and pyridostigmine, these are drugs are reversible anticholinesterase. So the main purpose of using these drugs is they inhibit acetylcholinesterase enzyme so that acetylcholine will not be hydrolyzed. So acetylcholine is present in excess amount that can be used for uh, muscle stimulation. Thymectomy. So that is antibodies are produced in thymus. The thymectomy can decrease the production of autoantibodies. And steroids and immunosuppressive drugs are given. And plasmapheresis to remove the autoantibodies. These are all the treatments for myasthenia gravis. The next one is Lambert-Eaton syndrome. So this is a presynaptic disorder. Autoantibodies produced against voltage-gated calcium channels. So the calcium channels are inhibited, so they don't open when the depolarization happens or the action potential arrives in the axon terminal. So there will be less exocytosis of vesicles into the presynaptic terminal, and release of acetylcholine is prevented. Impaired acetylcholine release in synaptic cleft, muscle weakness is common. So this is the summary of neuromuscular transmission. So I hope you understood the neuromuscular transmission very well. Thank you.